This is Dr. Wilson Wong, founder and CEO of WD Home. It's such a pleasure to be able to talk to you about our medication optimization feature that we have within a comprehensive product. I thought a good way to talk about its practicalities to go through a few cases with you, with the objective to show how we improve older people's lives, both in terms of quality and quantity. So in this example, we're looking at significant cost savings to an individual who's on a very expensive drug like Eliquis, a blood thinner that can't be discontinued. One would think this would be the focus, but there are many ways to increase the efficiency of a person's drug list. In this case, there's a 76-year-old woman with multiple diseases, but namely heart disease with atrial fibrillation requiring the Eliquis, and but also has renal disease and hip joint disease, and is wheelchair dependent. She's taking 14 medicines that are depicted right, and their cost is summarized to the right of the number 14. The cost of these medicines averaged out for what Medicare has to pay drug company, $52 a day, and $18,554 a year. This is much higher than the typical average medication expense for an older individual. So kind of an easy way to decrease costs is to look at the drugs that could be substituted for generics. And in this case, there are 5. And you see that we can drop the cost significantly by a total of $2,482, so 14% of the original cost, by substituting especially Lexapro, which is an antidepressant, with the generic, which is escitalopram. That decreases the cost of the medication $2 a day. And then also the potassium-sparing diuretic aldactone replaced by spironolactone. And again, the definition of generic is that there is no difference in efficacy. It just doesn't have the label. Now, let's pretend that you didn't want to have that as a starting point and you just wanted to get rid of dangerous medicines. Even without seeing the individual, we can look at the evidence base and eliminate the following drugs: Prilosec, Trazodone, and gabapentin. Now, Prilosec, this is a proton pump inhibitor. People say, well, what's bad about that? Well, these have been, over time, they lead to osteoporosis and risk of fractures in someone already with hip joint disease. Also, it's hard on the kidney and can lead to kidney disease, let alone exacerbate kidney disease in this individual who has grade 3 kidney disease. Trazodone is an antidepressant usually used for sleep. Usually it's at 25 to 50 milligrams, but this individual is on 300 milligrams. It's because this person has a history of depression, not depicted, but remember, the individual is already on the Lexapro. And they can be used in combination, SSRI with the SARI, but the trazodone is usually not at such a high dose and just used for sleep. And anyway, these two have to be given in combination in very close collaboration with the older person's doctor. In this case, the two at very high doses probably indicate that might not be happening. Then we have gabapentin, which is used for neuropathic pain, and although this individual has pain due to hip joint disease and is on oxycodone as codone as needed, there's no indication that gabapentin, that there is neuropathic pain, usually due to things like limb loss or brain disease, spinal cord disease, etc. And so under the algorithm, gabapentin would be eliminated for a cost savings of $1,622 total, or 8.7% reduction. How about drugs that have limited effectiveness? Well, one would be a combination stool softener and propulsive mechanism with Senna. one would ideally clean someone out with this medicine and then maintain through medicines. So a daily indication is usually not needed. Pravastatin is a drug that reduces levels of cholesterol, and it has not been studied in those that already have heart disease. And again, can have negative effects, especially on the kidney. Although it is used for those that have kidney disease, again, it would be used for those who have kidney disease who don't have a history of heart disease. So we could eliminate these two drugs safely and achieve a savings of $2,166 now and 11.7%. This is additive to the savings as before. And again, we go through the exercise of getting rid of generic or substituting brand names for generics to achieve a total decrease of 21% or $3,859 for this individual. This is a significant cost savings, and of course, scaled across an entire population in a caregiver business would mean substantial savings to the individual through copay or through Medicare, the provider. In this graphic, I'm just sort of showing pre costs and post costs and eliminating the drugs that we thought could be eliminated. Okay, so let's look at this another case, a case of an individual who's just taking too many non-evidence-based medicines. And unfortunately, this is a very common occurrence. About 30 to 40% of all medicines that older people take are not according to the evidence base. In this case, we'll just tell you that the individual is a 70-year-old male with dementia. Again, has multi-organ system disease, but probably doesn't rationalize being on 22 medicines at a cost of $4,623 a year. Now, this is much less than the previous individual because this individual doesn't have a medicine like Eliquis. However, the individual is on Ozempic, the famous Ozempic, but there is a generic for this, and even though it's still very expensive, you could achieve a cost savings of $516 a year, or 11% of the total. And we see a graphic about the difference between name brand and generic. Okay, so assuming that we do keep the generic semaglutide, let's look at the dangerous drugs. Well, in this case, there are many. First of all, the individual is on around-the-clock acetaminophen every day for years, and that has too much pressure onto the liver. If the individual has so much pain, then there will be other choices for that, including patches. Then we have around-the-clock meloxicam, which is NSAID, which will cause an upper GI bleed with time. What's really interesting is that the individual has 3 types of as-needed NSAIDs, so the combination will put the individual at undue risk. Now, gabapentin in this case is used for neuropathic pain, but the individual already has 2 other medicines for that, and that is baclofen and ropinirole. I'm sorry, not neuropathic pain, but restless leg syndrome. So it's not indicated to add gabapentin to this regimen. Then we have metoprolol, which is high blood pressure medicine. There's been a lot of studies that show that if individuals are within 140 and 150, that you would allow them to not be on antihypertensive because of the risk of hypotension, especially when someone doesn't eat that much or is let's say on a statin, to keep them off. Now, even if one decides to be on a metoprolol, it would not be the first-line agent for a high blood pressure medicine. Because you see from the list that the individual does not have heart disease, which would be one rationale for being on metoprolol as a high blood pressure lowering agent and an agent that decreases the work of the heart. Then we have the proton pump inhibitor. Again, you should not be on that twice. And in this case, there's 2 different types of proton pump inhibitor. For someone with dementia, these medicines have been linked to decrease in cognition at worst. At best, one should not be on full-time acid blockers. And finally, the same issue of trazodone as before. It's not something to be given every day, although in this case it is a lower dose. And then tramadol is an opiate, and of course will cause addiction and should not be used as a daily pain medicine. Then we look at those drugs that have limited effectiveness. We have another version of a cholesterol lowering agent, fenofibrate, again, not studied in those with dementia, and of arguable effectiveness with someone that has so many other issues. Then we have this, at least the generic version of the paracolase, but still shouldn't be on it daily. The individual's already on multivitamins, so it doesn't need to be on thiamine. So with all these changes, we have a savings of $1,527, and that's a 33% reduction. Now look at the dramatically simplified medication list from 22 down to 10. Now, one could argue that 10 is already too much. However, 10 is better than 22, especially if it doesn't affect outcome of health. And that's what I want to end with. By simplifying medicines, by reducing medicines that aren't necessarily, by definitely getting rid of dangerous medicines, the lowest proportion of decreased hospitalizations is by 20% because you prevent upper GI bleeds from chronic medicine use, you prevent falls from too much gabapentin or too many use of antipsychotropics, you prevent cognitive decline that can be linked to the statins, and renal failure, et cetera, et cetera. Polypharmacy, having too many medicines, is an independent risk factor for hospitalizations for reasons that we don't know, but usually related to interaction of the medicines. Now, if we could put a number to this, this would be about $1 million in savings per 1,000 seniors, assuming a cost of hospitalization about $13,000 a day, which would be the going low rate. And looking at the future of Medicare, the future integrity of our healthcare system for seniors, we have 6 million seniors receiving moderate to full caregiver support. And if we could achieve these outcomes, these gains, this would be a reduction in $4 billion annually. 10% of older people will die when they're hospitalized. So you want to think that if there are preventable causes of illness, that we would never set up a situation where, ironically, medicine is used to put older people in needless harm. I'd like to thank you very much for your time, and of course, am always available for questions, discussions, and consult. Thank you so much for your work in the older person care space. You are admired.